Thank you so much. So thanks everyone for joining. I can see that some people are still trickling in, but given it's 3 minutes past, I will just kick us off with today's webinar. Um, so really, the purpose of today is to support you with connecting suitable patients in line with your local criteria to the Aviva Tier 3 weight management service. We'll guide you on the context of this, and none of this will come as a surprise to you in terms of the background for obesity, the impact it's having, but also we'll talk you through the structure of our service and then guide you through some of the tools that we have available to support high quality referrals to the service. Although this webinar is mainly focused at those ICBs who have had perhaps more restrictive criteria, tighter criteria around referrals, it will be of relevance to those of you from other ICBs, and we will signpost you to the right place to look for your own ICB referral information. So I said a moment ago that today is meant to be a double act. So myself and Dr. Wasim Majid. Dr. Wasim Majid is the lead consultant within our service, and I know he is having some technical difficulties with joining, but hopefully he'll join us in time for some of the talk and particularly the Q&A towards the end. So I'm Dr. Shane Mehta. I'm the medical director at Aviva. I'm also a London-based GP, and I have experience providing clinical leadership for diabetes and weight management services at ICB level. And it's through that lens that we try to make things as easy as we can for busy GPs and those of you in primary care referring into the service. This is our brief agenda for today, an overview of what we'll cover. I've already alluded to some of this already, so next slide, please. So a little bit about Aviva. We're one of the leading partners for the NHS when it comes to diabetes and weight management. We provide a range of services, both within the diabetes prevention space, diabetes remission, and of particular relevance for today, our Tier 3 weight management service, which is our CQC regulated consultant-led service. Next slide. You'll see that we triage patients so that each journey is personalized, and our programs are specifically designed to have the latest, ensure the latest incorporates the latest evidence and guidance for health systems. We have a presence in 100% of ICBs within England, and we've been providing Tier 3 weight management services in this space since 2017, and it's in the last few years that we've introduced GLP-1 specifically. Next slide. So what drives us? Well, the end effects of obesity mean that it's too late for prevention alone. We know that obesity is associated with a number of conditions. It's the predominant risk factor for cancer, only behind smoking. And it's one of the main drivers for type 2 diabetes. Now, this is a particular concern for us in the UK, where we know that there's been a 40% increase in type 2 diabetes under the age of 40. And of course, when we look at the economic modeling, the costs multiply. You know, the costs of treating diabetes and its complications alone are at 19 billion. That's 4% of GDP. So that's what drives us, try and reverse that trend. Now, when we look at the data of supply and demand, we can see that NICE estimated that 4.2 million adults living with obesity would be eligible for Wegovy. There's a complete mismatch between the supply in the system for Tier 3 weight management services and access to GLP-1s. And this risks a two-tier system emerging and we've all seen that growth in private providers treating fee-paying patients in that space. And we're trying to ensure that we can ensure equitable access for patients and widen that access. And yeah, that's a really key point to note. As a trusted NHS partner, none of our patients pay, and we don't take on any fee-paying patients. We only work in partnership with the NHS to deliver our services free at the point of use. Next slide. Just a brief overview to show what is known already in the evidence base around the impacts of weight loss. And why does incremental weight loss matter? Well, you can see that, of course, there are the cardiovascular benefits of even 5–10% weight loss. But you can see the wider benefit, including improvements in osteoarthritis, and also clinical trials showing improvements in obstructive sleep apnea and asthma in particular. So the impact is far-reaching. Next slide. So we know that for many of you, the areas you're joining from, the criteria for access have become stricter. And I won't dwell on the why and what this means and the restrictive nature of this, but essentially we want to work with you and your local systems to connect the patients that meet this criteria so that at least they can access the support they need and deserve. So at this point, I had anticipated handing over to my colleague, Dr. Wasim Majid. Wasim, are you on the call now? I can see a link.
Yes, I am. Could you hear me?
Thanks for joining, Wasim. I'll let you introduce yourself and thank you.
Hi, everyone. How are you doing? I hope you can hear me. So my name is Wasim Majid. I'm the lead consultant endocrinologist for Viva. Thanks for the introduction, Shane. So I just wanted to start off with a simple observation from daily clinical practice, and I'm sure that we can all reflect on this too. So we are no longer dealing with obesity as a lifestyle issue. I think we are managing it as a relapsing, remitting, progressive, multi-system disease that is now driving our cardiometabolic workload more than any other single factor. And yet the way that our system has historically responded is super fragmented. Lifestyle interventions here and there. We have introduced sort of pharmacotherapy in an ad hoc fashion, experienced barriers to referrals, and we've lacked a single coordinated pathway that is both clinically robust and scalable. This is precisely what the Aviva Tier 3 program was designed to address, where we've tried to redefine and rethink what a Tier 3 model is, to understand the needs of our patients and obviously make this a very efficient and efficacious service for our patients. Next slide, please. So what makes this program fundamentally different, and I've got a lot of NHS traditional care, is that this is not just about delivering education, but it's about delivering specialist medical care. Whilst the service itself led by team with MDT level intervention of several touch points in the patient journey, while ensuring that this is. And the key thing here is not just integration, but also
Sorry, Wasim, I can't really hear you too well, actually. Mike, could you guess? I think
it's very quiet. Do you think, Tara? Or
yeah, that's okay. That's better now. Yeah, if you could.
Is that better? I'll just lean in, I think.
Yeah, that's better. Thanks, Wasim.
Okay, fine. Do you want me to do this particular slide again, Tara? Or
yes, yeah, if you could just start this. Yeah, if you could. Thank you, Wasim.
Fine. Okay, no problem. Right. So I guess what makes the Aviva program fundamentally different is that we are not just delivering education. We aim to deliver specialist medical care and ensure that the wider MDT and the support from the wider MDT is interfaced and integrated into several touch points in the patient journey. I guess the key thing for me is not just simply integration, but to also ensure that there is a personalized model, taking into consideration the needs of every patient. Next slide, please, Tara. So a core strength of the program is the MDT. So as I was mentioning previously, it is led by a consultant endocrinologist, where we are an ever expanding team, as you can see, and we've got high level clinicians that help patients at several touch points in their journey. What I think is particularly useful and important to note here is that the service in itself is structured in a very flexible way. So, for example, if there is an issue with the patient and if they require higher level intervention, perhaps with extra consultant support, then there are forums built in across the week, in fact, to enable this to occur. So, for example, we've got consultant-led meetings on a daily basis, and we've got an MDT that runs every week that patients are typically referred into to ensure that they receive the robust care in terms of ensuring that their clinical outcomes are enhanced. Next slide, please. So core strength of this digitally enabled track is personalized element of this. So we support patients from day one. The availability of a digitally enabled service allows patients to engage from the very beginning of their patient journey. And what is particularly unique is at the end of their 24 months, don't necessarily just say, here, you have now simply completed your pathway. We have built in a safeguard and an off-ramping that allows patients to focus less on dependence on weight loss medications, then allows your life to take control the point of their journey. And this.
Sorry, Wasim, your audio is not going. I'm going to suggest that Shane actually would you take over this section, Shane?
Yeah, let me step in. So
sorry,
thanks,
Wasim, your audio is not working too well.
So I think what Wasim was rounding off on is that throughout our pathway, patients receive diet and lifestyle support and coaching. So we use that magical mix, I would say, of human coaching supported by AI-driven apps where patients can submit daily photos of their food and their eating habits. And of course, that can create a behavioral nudge loop to help change their behaviors, but also helps our coaches tailor their individualized plan. And we really focus on that throughout our pathway. You know, patients can't just join and just have the GLP-1, which, you know, I can tell you some patients want to do. We absolutely mandate that they must have and must engage with the dietetics and lifestyle support, because that's what brings sustainable weight loss and helps build those behaviors that will last a lifetime. So that's really the drive there. Next slide. So I've talked through some of this already. You know, often we get asked, what is this app? How does it work? But there are so many features. Some of these are summarized here in terms of the self-tracking it lets patients achieve, the analysis of food, the feedback it can provide to build those healthier habits. Next slide. You'll see that in terms of the app and what it helps us monitor, and we proactively monitor so both uptake of the app, but also retention throughout the program. And we use that as a quality marker throughout. Patients feedback that the app really helps them track their mood, their activity day to day, and encourages them to build those healthy habits. It gives them an opportunity to get instant feedback. And then we have those live touch points with the coach to review these and again, build the next steps plan of their journey with us. Next slide. This just gives you a brief snapshot of some of the overviews that patients can see and how they can tailor that journey for them through looking at their progress and their visual tracking of their weight. They can track the meals they've eaten. There's also prompts about staying hydrated, which of course contributes also to well-being. But you'll also see the barometer at the top of letting them know if the food they've submitted has been really high in carbohydrates or sugar, for example. And all of these things help learn and build in healthy eating habits. Next slide. So in the next few slides, I'm going to try and give you an early snapshot and overview of the outcomes and impact we've seen within our service. So you'll see that throughout our program, we treat obesity, yes, with a consultant-led medical model and that expert input, but the wider MDT is so key. And it's through that holistic delivery of care that I believe we achieve the outcomes that we do. And if you look at the outcomes, so far, what we can see is this is of course including all of our patients who have reached this milestone. 15.2% weight loss is the average that we achieve using Wegovy, supported by that MDT, dietetics, lifestyle and coaching support. And that to me is no mean feat, because we are achieving trial equivalent outcomes, but with perhaps a much more complex population. And that is absolutely something we're seeing, particularly in ICBs like yours, where you're joining, where there is much more restrictive criteria, where the patients that are referred are definitely at the highly complex end. We are seeing similar results to trial settings, but in a much more socially complex population. Next slide. We are also monitoring the wider impacts on their mental health, their quality of life, their general health. And you'll see here, the dark green shows perhaps where they were at the start of their journey, the percentage that reported that their general health or quality of life was good or better. You'll see 16.4% at the start of the program, but 6 months in, there are improvements in all of those parameters. Patients report significant improvements in their general health, quality of life, physical health, and mental health too. Next slide. Now, in terms of the program and how it's delivered, one of the things we want to do is to instill healthy nutrition and eating habits. And we are actively tracking patients reporting emotional eating and the frequency at which they do that. And you'll see a huge improvement, a fourfold improvement in patients reporting never or rarely for emotional eating. And we know that's significant because that food noise and that the emotional eating behaviors can often feed into weight regain and poorer eating habits. Next slide. So we were featured in the press fairly recently because there is such huge interest in obviously the economic impact of obesity, particularly when it comes to people taking days off sick and the costs related to that. And early evidence from the patients we've captured shows that patients take 35% less sick days, and that the economic benefits of that when modeled are huge. So next slide. I know Wasim, you're going to take us through the eligibility criteria. I don't know if do you want to have a go, or should I just continue?
I think it is best perhaps if you continue. I've been having some issues with my audio, Shane, if that's okay.
That's okay. Thanks, Wasim. So in terms of the eligibility criteria, in the next few slides, what we'll try and do is highlight at high level what the eligibility criteria is for the specific ICBs. And we're covering just the 4 ICBs here specifically today, 4 or 5 ICBs with really tight and specific criteria. But on, I'm sure Tara or Jamila will be able to paste them to the chat, that on our website, we have the eligibility criteria for all ICBs listed. So if you're from a different ICB and want to check what your eligibility criteria is, it will be there for you to see. But of course, for those of you who are in ICBs with tighter criteria, I'll just try and highlight at high level what the criteria are. Of course, we'll share these slides with you straight after as well, so you can have a look and keep this as a reference point for you to look at, okay? So you can see here for Cambridgeshire and Peterborough, and I think there are similar criteria for the other ICBs. So I'll just talk through this one in a bit more detail. You know, in your specific ICB, access to the programme is more aligned with the NICE tirzepatide guidance for primary care, the tighter criteria that has been worked on with NHS England. And you'll see here that patients have to meet the BMI threshold of greater than or equal to 40, plus have at least 4 of these specific conditions. So established type 2 diabetes, hypertension that requires drug treatment, having evidence of cardiovascular disease, obstructive sleep apnea, and dyslipidemia. So these are the 5 conditions that guide eligibility, and patients need to have 4 of those 5 conditions in addition to the BMI criteria. So you can see it's different from the NICE criteria, but this is the exact criteria for access for your particular ICBs. And later on, I'm going to talk about some tools that we have that can help you identify suitable patients to make it easier. Next slide. So in Cheshire and Mersey, you can see again, similar criteria, but the added ask to show that, or just confirm that the patient has attempted to engage with the community weight management service in advance. And then they need to have 3 of these criteria that are listed here. So a slightly narrower list, but they need only 3 from that list. Next slide. For Kent and Medway, again, very similar to the Cambridgeshire criteria, where patients need to meet the higher BMI threshold of greater than or equal to 40. You'll see for all ICBs, there is the ethnic minority adjustment that you can do by reducing the BMI threshold by 2.5. But again, patients need to have 4 out of 5 of these criteria in order to be referred into the service. Next slide. So West Yorkshire, very similar again, confirming that the patients have engaged in another lifestyle modification pathway, but also confirming the same 4 out of 5 criteria. But they also have this additional criteria where patients can meet the BMI threshold, but then also perhaps need to access weight management support to access critical or urgent surgery or intervention. So just highlighting that flag. And then next slide. So for South East London, you'll see that the criteria are broader still, and there are some really specific conditions that are listed. So of course, one of the qualifying criteria is the same as for the other areas in the sense of the BMI criteria and having 4 out of 5 of these conditions, but there is an or there. So for some patients, you may consider referral with a lower BMI, so a BMI of 35 or 32.5 for those from ethnic minority groups, and 1 weight-related comorbidity, which isn't restricted to these 4 that are listed here. Any weight-related comorbidity plus 1 of these qualifying criteria. I won't go through each of them in detail, but you can see, you know, there are patients that who may need surgery, maybe on the list for organ transplant, those who are waiting for a planned cancer treatment, and therefore, and where there is a weight loss goal that would help make that happen, but also those patients who may need to access fertility services, where weight loss is considered needed for assisted conception. So this full criteria will be shared with you. I know it's a lot to take in, and I've just given you a very brief overview, but we will share the slides with you. And of course, on our website, you can also access the exact referral criteria for your ICB. Next slide. So we wanted to highlight and bring a case to life. So this is one that the team have shared in terms of, this is Nicola. she's a patient who was eligible for specialist weight management support within our service. You can see that she has a BMI of 46.7 at the time of referral, and she had type 2 diabetes, cardiovascular disease, and non-alcoholic steatohepatitis. So far, she's been on the journey with us for 14 months. She's achieved 2 stones weight loss since the start of the program in July. She has also established a home exercise routine, which she feels positive about. And she reports that, yes, she had some side effects related to the medication, but these have been worked through, and she stays with us on the program, reporting overall that her life is better now. So just wanted to introduce that and to bring some of the patient stories we have to life. But you'll see that we have lots of others that we try and share with areas, and we'd love to share specific ones from your areas as you make referrals to our service. Next slide. So in the next few minutes, I'm going to take you through the referral form and also some tools that we have available to identify suitable patients. I'll also talk you through some of the pitfalls that we sometimes find in maintaining high quality referrals. But the idea is to give you the tools and some tips to just make sure that we sustain those high quality referrals from a referrer perspective, but also to ensure safe care for our patients. We're really, really aware that for those of you working in ICBs that have quite restrictive criteria, you may not just automatically just know which patients to refer in, and it's not as simple as just looking at your obesity register. So how can you identify suitable patients within your clinical systems? So please do feed back to us if you're using particular digital systems or search systems for population health management, or to enable search and refer. But we know that one of the providers that lots of practices use is Ardens. So here we've included 2 screenshots, both for EMIS and System 1s. So those of you who have access to Ardens can access these searches in this way on population reporting and all clinical reporting systems. And cohort 1 would be the best one for you to look at because it maps most closely to the NICE tirzepatide guidance for primary care for this year. So until April 2026, it's cohort 1 that is the focus, and it gets you a good chunk of the way towards identifying suitable patients in line with your ICB criteria. You will, of course, have to look at the ICB criteria to check if there are any tweaks or quirks that you just need to factor in, but I think it will really help narrow the list and help identify those suitable patients quickly. And for those of you that are using other search repositories or tools, again, do feedback. We are looking to sort of partner and work with those providers so that we can ensure these searches are accessible to you. But next slide. Our team at Aviva will do everything they can to support those of you that may not have access to the Ardens searches. We do have specific EMIS searches that we can share with you. So if you don't have access to Ardens, the links and contact details here are for the key contacts in your area. So that's a named contact who will act as a single point of contact to support GP referrers from those areas. If you have questions or pre-referral questions or want support with accessing these searches, then I think contact us. If you don't have access to Ardens, as I said, we can share the EMIS specific searches. If there are other search providers that you normally work with, flag it to us. We will look to build these in and so that we can share it with you and really streamline that process for you. Next slide. So we know that in general practice, you're really busy. And as a practicing GP, I know the pressure that we're all under. And actually, we really, really want to drive that noise that happens when a referral is sent and things are incomplete. It can cause delays for the patient. It can add work, I know, for GP referrers. And we're really trying to streamline that process to make it as simple as possible. So how do we do that? Well, we've really identified a core minimum set of parameters that are required as part of that high quality referral. And it enables us to deliver safe care without having to come back to the GP for more information or more questions. So we really want to try and smooth that journey. In terms of the referral form, for those of you that have access to the Ardens repository, you'll find that it's available for you on there, and many of the parameters should auto-populate. If you work with a different form provider, please do flag it to us and we will try and work with them to make sure that the form auto-populates for you there as well, reducing your workload and making it easier. Next slide. So this is a snapshot of one of the core parts of our referral form. You'll see that we require a weight reading that's validated in clinic and within the last 12 months. But there are some blood work parameters that we need. We find that sometimes within these 5 ICBs, when we've analysed the data, we can see that about 8% are missing thyroid function tests and 7% missing the LDL result in particular. So just flagging that these are core parameters that we need in order to process the referrals. They help guide eligibility criteria for patients, but also ensure we can deliver care safely. And so these are the criteria we ask for, but just so we can streamline the process, these are the ones we front load, and we need them within the last 12 months in order for them to be valid. Next slide. Retinopathy. Now, this is one where I've taken away as perhaps work in progress, and you'll see here that we find that often 13% of cases this aspect is left unfilled. Why? And I think there is probably things for us to take away in terms of how the form is structured. But at present, the key message here is that whether the patient has diabetes or not, please do fill in the section. You'll see that there's a tick box or check box just to say the patient does not have diabetes. So if you tick that one, that's all good. And I think that will probably account for the majority of cases where this is left blank. It's most likely because the patient doesn't have type 2 diabetes, at least that's my hypothesis. But I think the key message here is please do complete this. If your patient has diabetes, then you must submit the last retinopathy screening outcome with the referral. If they don't have diabetes, please just tick to confirm they don't. Okay. Next slide. So how can you connect patients to our service? As I said, the tools that we've presented here in terms of to identify them using the search and refer tools within Ardens and other clinical systems will definitely help locate the right patients and help make it easier to connect them to the service. Of course, if you're working with other providers, do flag them to us. And as I said, we will work with you to get those searches on. We can also supply searches to help you identify those patients. You can refer patients using NHS Mail to this email address, but of course also via ERS referral. And this information is also available on our website. And really my call to action today really is, based on the information you've heard, I hope you feel able to connect patients to our service and understand the high quality care that we strive to provide within the service. We'd really like to hear from GPs of your experience referring in. And I'd urge you in the next few weeks to take these tools and connect at least 5 patients perhaps into the service as a starting point, as a tester. Give us a go, feedback depending on how that experience has been for you. We'd love to hear from you. And I know, as I said, we flagged the 3 contacts for your particular ICBs as an easy way to let us know if there are specific quirks or bits that we need to improve on. And we are always striving to better the service we provide, both for referrers and patients, as we look to improve access to tier 3 weight management across the UK and in particular. So thank you. So at that point, I'm going to segue into Q&A. I think we still have a few minutes left. I can see in the chat that there's a comment about could we have the form on DXS, and thanks for flagging that, and we will definitely look to connect with you. And if you could just state which ICB that's from, just so that we have that, but I think we can look that up anyway because we've got your practice name there. Tara, are there any specific questions on the Q&A that we should take at this point in the final few minutes?
Yes, absolutely. We've got one question from Jessica, who's asked around the current wait times from referral to the initial patient contact and then onto the programme.
Thanks for flagging that. So I'm going to hold my hands up here and say that I am not, I don't have the latest information on this, but I know that when patients are referred into the service, their referral is processed within a few days, and they're given an indication of when they will be seen by our dietitian, perhaps in the first instance, to go through the initial dietetics and lifestyle assessment. And my understanding is that's within a few weeks of referral, but we can confirm that in writing as well, just so that you have access to that information. But we do keep patients informed throughout that journey so that they don't keep coming back to the GP. So the moment their referral is processed, we have a system whereby weekly patients are updated as to where they're at in that referral process journey, and they'll get seen.
Thanks, Shane. We had Fiona, who's just said about how she has a patient who has lost 10 kilograms since being on Aviva's program, which is amazing to hear. So thank you for sharing that. And then can you see the next two questions, Shane? I don't know if you've got time to answer any of those ones.
Thanks for confirming. So I think in terms of the tier 1 and 2 pathways, we don't really do any additional checks to check that patients have completed those. You'll see if your ICB requires confirmation, they normally put that in the referral criteria, referral form, just for at the point of referral, just to confirm that they've engaged with a program. So if that is required in your ICB criteria, it's just a case of ticking that on the referral form and confirming that is the case. We wouldn't do any further checks around that, just to streamline that process. We'll trust what you submit to us, and we rely on that information in that first referral to confirm those sorts of elements. In terms of access to semaglutide specifically, I think the question here from Ranti is there access to semaglutide, and if so, is the criteria still the same? So I'm not sure if we can just bring that slide just very briefly back up on screen for South East London. The access criteria for South East London is there, and that mirrors the access to Wegovy is semaglutide, and that's the drug that we offer within our service. And in order to access that, patients need to meet this specific criteria. So I won't go through that in detail there, but it will be shared afterwards as well. But you can see the criteria follows the tighter BMI and 4 comorbidity criteria, plus the alternate route for patients who may be waiting surgery or other things.
Shane, I was wondering if I can add to that. I hope my audio is a little better now, but if it is very crackly, please feel free to interrupt me. But I thought in light of that accessibility criteria that I provide some context into where these sort of criteria have actually been derived sort of from. So it's certainly based on the two NICE TAs, and as you can appreciate, there has been new tirzepatide NICE variation criteria, and some ICBs have chosen to adopt that for accessibility for Wegovy / semaglutide as well. Now, you may have also noticed that there's some variation from ICB to ICB, and certainly the Southeast London ICB have also adopted accessibility criteria from a joint position statement between an obesity working group and the Society for Endocrinology. And I've just popped in the link in the chat for those that wish to read that guidance for more context.
Thanks, Wasim. Thanks for sharing that.
We just had one more question, Shane, about the Aviva app. I don't know if you could talk a little bit about how the app sort of determines the fat, the sugar from the photographs that our patients send via the Aviva app.
Thanks. So I think this is something that's forever evolving and forever improving, because this is where the app has so many features. But one of the areas that we are actively looking at with this is that patients submit information. It drives analysis of data using AI to try and ascertain what the food is, what the typical mix of fats, protein, carbohydrate, etc. would be in that food. And this is something that continues to improve. The more information that's fed in by patients, the more the app improves in reliability and accuracy from that regard. It'll always be a guesstimate rather than an exact science, but I think the feedback we've had is that it's pretty good at giving people an indication of the foods that are good, the foods that perhaps might not be so good or might have the slightly imbalanced mix. But yeah, that's broadly speaking how the app works and how it's fed in. So it is AI driven, but then there are also our dietitians that then feed into that conversation where the AI can get it wrong sometimes, etc. And that iterative process continues to happen.
Thanks, Shane. And following on from that, Kelly's just asked around the support, whether there's face-to-face or if it's just online support that we do.
Thank you. So I know for some of our Aviva services, there is a face-to-face offer, but for the tier 3 weight management service specifically, all of the care is remotely delivered and it's online. We personalize that to the patient. So if patients don't have access to a smartphone or even the app, then sometimes we do have a telephone pathway supported by materials provided in written format to patients. Lots of our patients are able to access that service, access our service using supported means, even where sometimes with the help of a friend or family member or an advocate. We do everything we can to make sure those that might be at risk of digital exclusion are supported to join. But on the whole, I have to say that patients report a really positive experience from that accessibility of support, and the fact that they have access to the Learn content and recordings throughout also supports them on that journey, as I said, in a remote way. But yeah, for tier 3 weight management specifically, the contacts are remotely delivered. There is no face-to-face care offer.
Great, thanks, Shane. I think we're at time, but we've just got one more question from Kelly. Is prescribing done through the GP?
That's a really good question. So in terms of when we initiate patients on Wegovy and for the length of their program with us, which is up to 2 years, depending on their engagement and retention on that program, throughout that period, we continue to provide the medication for patients. We do not transfer that responsibility to GPs. That continues to remain with us. And also just to reassure that when patients have side effects or queries about medication in between their appointments, we have a prescriber queries line that patients can use, and we aim to respond to them. It's a non-urgent service, so it's within a 72-hour response time is the absolute max. We're targeting 48 hours for that, but just to these are the measures we put in place to ensure that work doesn't transfer to GPs in those instances.
Thank you, Shane. I think that's all for the questions.
Thank you. So I think we're at time. If there are any further questions, we will try and get some written responses to you. I know you've got your individual ICB contact details here for our Aviva team. Please do engage with us. We'd love to hear from you. We'd love to hear your feedback, and do take that call to action. Please do connect. I'd encourage you to connect 5 patients to our service in the next few weeks and let us know how that goes and let us know how that experience is. And thank you to those of you that have, I think, posted some of your experience in the chat, and really, really glad to know that the positive impact it's had on patients that you have referred in. So thank you, and thank you for joining.